I want to welcome everyone this evening to what I hope will be an exciting program, and we all learn together. So, Lou, you want to say hello?
Hello. It's great to see everybody. And honestly, Tony and I know you've worked all day. It's the end of the day. So we want to make sure tonight's worth your value. And so from Catapult, we do value your time, and I'll click away. So Tony, if you'd proceed, because Tony's in control tonight. So we review a ton of products every year. And the way the review process works, which we'll get into very, very briefly, we have usually anywhere from, I would say 10 select to 25 reviewers review a product. I'm going to highlight some of the highlights of a product that we're going to be focusing on tonight, but we're going to be focusing on far more than just a wonderful product line. And tonight I'll say thank you to SDI. They've been a wonderful partner to Catapult as we enter literally our 20th year. So thank you, SDI. So earlier this year, we were privileged to review a product called Luna 2. SDI has been making composites as many manufacturers for years. The issue for us, or the question to us was, and Tony, you'll click forward, what really made this product stand out? Was this a Me Too product, or was this not a Me Too product? And Tony's going to show his clinical cases tonight. And I think when you look at Tony's clinical cases, you won't be able to understand the number one quality, but the second quality you will. So the number one quality that absolutely stood out was handling. And handling for a dentist, as you all know, we are beyond picky. So I'm going to show you the results of our survey. So this is what happens inside our world. There's about 20 questions, and each doctor, each reviewer has to answer each question and make comments. This was a very unique aspect of this composite Luna 2. When we asked, is it too hard, is it too soft, or is it just right? Very rarely do 100% or all 15 reviewers say it's just right. In fact, it never happens for a composite. So 100% of all 15 reviewers said it handled just right. Now, the quality, and Tony will go to the next slide, the quality of this product, part two. Yes, it has a lot of the same low shrinkage and other wonderful properties, but what also stood out in this product was the color shades. So this was very remarkable. So when you look at it, and Tony, if you click one more, you'll see a couple arrows show up. What you will see is that in our reviewers, when they were asked, selecting the shade, was it easy? 80% said yes or agreed, and another 3 strongly agreed. Now, there's a hard way to differentiate strongly and agree, but the bottom line was that this is a very simple and very accurate shade guide. So what's very interesting is I just had another company reach out to us and ask us, Lou, can you ask your guys and gals, which company makes a true accurate color to the Via shade guide? I told them, you got to check out Luna 2. So now I'll show you why. Luna 2, it's called logical shade matching. So what they did was they prioritized value. In other words, kind of the translucency, but the translucency of the gray scale. And that's what value is. And so what SDI has done is they've arranged pigmentation in each composite to literally increase as each color increases from A1 to A2 to A3. But the result is you'll see in Tony's work, and it's amazing, giving Tony's disability to do quality dentistry. And I'm totally kidding, but you're going to see, and it kills me to say this, how chameleon his work, and it just blends in. Now, you're going to see, for example, on the next slide, let's go to the next slide, Tony, what this means. When you put a 1 millimeter shade of, let's say, an A1 over a one of let's just say on the far left, SDI, you see a natural translucency through. So if you're doing an interior composite, a class 4, and you want to do a long bevel, and you want to blend it in, and you only need a thin layer to blend it in, this is going to blend it in beautifully like an enamel color. But as you're doing a posterior composite, where it's 2 to 2.5 or 3 millimeters, then what you'll see is a true, what I would call Vita shade, because it's its true color. Now, there's another key thing here, and you've done this before. You're doing a class 1, and it's not deep. And if it's not deep, and if you only use 1 millimeter or 1.5 millimeters, you're going to see that dent and floor. You've been there. I've been there many times. So then all of a sudden the composite's too dark. Too translucent. So what SDI has given us is a wonderful shading way or different shades of how to do this. So let me kind of go through this one slide. So before you click forward, Tony, 7. What they've done, what SDI has done is they've given us 7 Vita shades. The majority are in the A family. And let's be honest, routinely, that's what we pick up. We pick up an A1 or an A2 and A3, and that's all pretty much Tony's work, except for his final class 5 tonight. There's a couple B shades. There's a couple C, there's 1 C shade. So there's 7 shades entirely of the Vita shade guide. There's no D family, but nobody picks up D. Okay. The number 2 means there's 2 opakers, A2, opaque, and A3. So don't advance yet, Tony. So what does that mean? So let's say you're doing a composite on number 30. It's 2 millimeters. It's on a patient, and the dentin's really dark. I would use O2 or OA2 and not A2, because OA2 will mask the dentin 2 millimeters. So you have your choice. You're going to use the opaquer more in posterior teeth when you're not that deep, because you want to shade the dentin. You just want to shade it. In anterior teeth, of course, you know exactly what you're going to do. You're going to layer a class 4 with the opaque A2 and then an A2 or an A3, of course. So the opaquer can be used in the posterior or the anterior. That makes it really unique in the shade system. Hit it one more time. So they have really 1 enamel color. So it's a translucent enamel for those highly aesthetic dentists who want to layer over in an anterior case. There's 7 basic colors. And the last one is they have 2 bleach shades. And it's really interesting because this is what's fun to be, I'll say, Lou in a Catapult. We get to talk to the companies. And this company, SDI, is already looking at a 3rd bleached color because people want bleached, twice bleached, and now 3 bleached. And Tony, who's done more veneers than pretty much most dentists in their entire career, knows what 3X bleach is. So odds are this company's going to come out with a 3X bleach. But in all sincerity, understand the simplicity of this when we're going to look at Tony's cases. 7 basic shades, 2 opakers, 1 enamel, and 2 bleach shades. Tony, take it away.
Thank you, Lou. So in my disability, I'll try to share with you some of the work. This is an accumulation over time of patience and working with this product. And as Lou has mentioned, this composite, it shocked me when I started looking at the immediate shades. A lot of times when you do a composite, you'll have some, the tooth will need to rehydrate, and that's when the true color will come out. But let's take a look. So our first patient, the patient came in, she says, I want my back teeth to be white. I want to get rid of some silver restoration, some silver fillings, and a gold crown. So when we look at this slide here, on the second bicuspid there, we see the typical amalgam breakdown. You see some marginal leakage, and over time, but this has been a great filling for this patient. I'm not sure how long it's been there, but when you look at this, what are some of our concerns? Well, on the cuspid, you can see there's been some wear and a little composite, and then you see that breakdown. But also, what is evident is we have some crays or some possible cracks. So this is what I refer to in all the years of dentistry. This is not unusual to see with the breakdown of an amalgam. And it's very common to see these crays and little cracks when we go to replace these amalgams. So I took the restoration out, and lo and behold, there is the minor crack coming across the marginal ridge and on the floor of the dentin. Now, what the literature shares with us is, what do we do about this? Well, the literature says that almost 90% of these cracks, they don't go anywhere. They stay in dentin. And remember, this tooth was asymptomatic. The patient had not complained. So what are our concerns? Here's the decision we have to make. Do you prep into the crack on the marginal ridge? Well, my concern there is, are we going to weaken that marginal ridge? That's a concern. Decision, what is the opposing occlusion in regards to this? Do we in fact have a plunging cusp that comes into that marginal ridge? And we've all, as clinicians, if you've been in dentistry long enough, we've seen it all. It does not appear from not seeing the opposing tooth that there is an indication that there is a plunging cusp. Otherwise, you probably would see wear or even further breakdown of that little crack there. Go ahead,
Tony,
Lou.
And I'm going to say this for everybody listening tonight. Every time you pick up a drill, to Tony's point, you have to evaluate each and every patient, each and every tooth. Because we live in a society where somebody sees this crack and they think crown. There's no justification in putting a crown on this tooth. And what Tony just said is, do you really want to drill through that marginal ridge? Or ultimately, as you see Tony's final restoration, are we creating an internal seal to stop any micro leakage? So I think what Tony and I are trying to get through here is, what is minimally invasive dentistry and what's proper dentistry, and how do they apply to this? Tony?
The one thing I would do is I would take an intraoral photo of this and share it with the patient and say, you know, I've explained clinically that I feel the tooth's going to be stronger. We're just going to seal this. It should not be an issue. We will certainly monitor it, but I would take an intraoral photo of this at that time. The decision was to bevel and leave the crack/craze line. The next decision, how do I etch and how do I bond? With our universal bonding agents, we have many options nowadays. One is, do we do the total etch technique? Total etch has been around for a long time, and most of us have all used it, if not all of us. We have selective enamel etch. What that is that you take your phosphoric acid, anywhere from 35 to 37%, and you just place it on the enamel. Now, why does one do this? For me, I don't do self-etch on enamel because I have seen enough restorations where what I call ring around the collar, the inorganic matrix does not appear to get broken down with our self-etching adhesives at this time. They're working on it. We're real close. And I prefer to make sure that enamel, I have a wonderfully etched enamel. And the last that is available is a self-etch technique. Now, saying that I prefer either total etch, selective etch, there are some clinicians, there is no wrong in doing a self-etch technique. It's just my preference. In this particular case, I chose selective etch. And you can see here that the etch is on the enamel surface after I beveled it. So first, I cleansed the preparation with a 2% chlorhexidine because it's an antibacterial. It will help seal and clean out that after decay removal. Then I did the selective etch for 20 seconds on the enamel. After I selective etch, I will rinse, and with a surgical suction, I will blot and dry it. Why surgical suction? we want to make sure that we get the entire etch off the tooth. We don't want it slurring throughout the mouth. We want to make sure that we get that etch. Next, SDI makes a wonderful universal bond. It's called zip bond. I took the zip bond, and I prefer the unidose, although it does come in the bottle. It's clinician's preference. And I placed it both on the enamel and the dentin. And I scrubbed that for 20 seconds, allow it to sit. And then after it sits, I will air dry it. Lou, talk to us a little bit about universal bonding agents.
Tony, go back one slide.
Yep.
I think key here, couple things. When you rinse, what you do is what you'll do is you'll take your surgical suction and surgically suction first, the etch off, then rinse.
Right.
I just want everybody to understand how Tony was talking. So surgical suction, then rinse. Now, as you blot dried it, now I just want this is a great picture. Why? As Tony is scrubbing his zip on, you can already see the glistening hybrid layer. It's just a perfect capture of that. But the key word is you want to scrub. You don't want to place. Now let's talk about universal bonding agents. Okay. So this is all we use. And I'm going to explain why this is all we use. And you can see a plethora of universal bonding agents in the circle. Why? They bond obviously to enamel and dentin, but they also bond to gold, zirconia, which is a metal. They bond to ceramics like Emax. They can bond to composite. They can bond to dry tooth or dry material. So when you're repairing a composite and you want to dry the composite, you don't have to worry about moisture in that because this is a universal bonding agent. And they can dry to wet surfaces. I mean, they can be applied to wet surfaces, but mildly moist, not overly. So this is the generation that can do all of these things. And what Tony did say, all of these products can be used in a total etch, a selective etch, or a self-etch. That makes them universal. Some can be light cured only, and some are dual cured. And obviously, you read up on each one, but that's the uniqueness of a universal bonding agent. Tony? So the next critical step is air drying. And I will just say to you, the number one thing you need is an air only handpiece next to your air water. Because when you hit the air on an air water vapor will continue to come out, and you are trying to create a moisture-free area. And when you're airing out your bonding agent, what you're trying to do is remove the solvent. And if you bring any water into it, you're going to break down the bonding agent, and you're going to have micro leakage and sensitivity. I think this is the most important step, Tony. So
I agree, Lou. And
right?
Lou and I, we practiced together. And when I joined him at his office and we had this dedicated air syringe, it was like heaven. We can't emphasize enough how important that is.
Wait, go back. So here's the technique, and the technique is critical. So now you've scrubbed your bonding agent on, and now you're going to air dry. And most people blast away for 2 seconds, and they wonder, why do they have sensitivity? That's why, because you're blasting your hybrid layer away and routinely bringing water in when you hit your air water syringe. And I know what you all do. You hit your air on the air water, and you think after you've sprayed it at your knee, all the water's out. It's not all out. Studies show it's not all out. So what you want to do is get an air dedicated. Second thing is, you're going to blow gently from a distance, about 1/2 inch. Then as you come closer for the next 5 seconds, yes, it's a total of 10 seconds. That's the DFUs for most bonding agents, 5 to 10 seconds. At a distance soft, and then come in a little closer, and you can go a little harder. Those are the 2 key rules. Let's talk about lighting. So now you're going to light cure for 20 seconds. And you want to make sure you capture the entire area. So you may have to rotate your light, especially as we'll show you in a class 2 or a deeper restoration. So you've air dried and you're going to light cure, rotating your light because you have to capture the whole area. Next slide, Tony. Two unique features with the Radii Cal CX. One is at the tip of it, you can remove the screw cap. You just remove it and replace it with a new one. So a lot of people like to put some kind of cellophane wrap over theirs. I do not recommend it here. With this particular unit, which is now a collimated light, which is a huge upgrade from their previous Radii lights, love this light. What you will then do is you'll just, if you start seeing more composite at the end and you can't just scrape it off, you just unscrew the old tip, put on a new tip, and now you've got a brand new tip. You don't need to isolate the tip. Second thing that's unique with this light is that it has a soft start. So it literally ramps up in the first 5 seconds. Now, the company believes this may minimize or decrease polymerized stresses. So just letting you know, it's a soft start and a screw cap. Tony, let's go on with your case.
So after I place a thin layer of flowable, which I do under all my composites generally, I then took and looked at the shade guide and I selected an A3. And I placed it over the flowable at 2 millimeter, layered at 2 millimeters and light cured. Again, to review what Lou talked about earlier, where we have our selection here, it was amazing to me how accurate the shade guide was when I first started working with the Luna 2. So here I'm polishing. Now I want you to pay close attention also, which I don't show the procedure, but once I got done with everything, 3 weeks later, put a new crown on. That custard was driving me nuts. And I unfortunately didn't take pictures, but I actually improved the anatomy and the guidance as well using just the Luna composite. So this was the final result. And I was very pleased. This was immediate. And, you know, I was able, you can see, we can sculpture. I am huge on dental anatomy. I just am on preparation anatomy. The grooves are there for a reason. Plus I like the artistic part, but this was one of the first ones I did. And I just love the shade. Comments, Lou?
I think the value here is the natural value. The value means literally the brightness in a value or a gray shade. And when I look at, and it kills me to say this because I'm complimenting you, but I will absolutely say the incisal totally changed of the canine, and this class 2 looks unbelievably natural. And let me also say, you go watch these presentations where they're staining the grooves and things like that. We don't do that. That is ridiculous. I mean, this is a class 2, and we've got to do it in time efficient way with a gorgeous material. So let's go to the next case.
So our next patient tonight, a high caries risk patient. This is our office is near University of Chicago, and this is a 24-year-old graduate student. This was the initial exam. Obviously, I had a discussion with the patient. Not obviously, I had a discussion. The patient drank a lot of soda, without question. And of course, the soda of choice was Mountain Dew. The chief concern was, he said to me on initial exam, daily my teeth are sensitive. And this was prior to any radiographs. As a grad student, he had limited funds, and he said, I can afford the dentistry if we can do one tooth at a time. So this is my initial bite wing. And I'm thinking, okay, one tooth at a time. Which tooth do I do? Obviously, tooth number 12 has a little overhang. Tooth number 13, MOD, poor existing restorations. You look down on the lower, deep decay on the distal of 19, decay on the distal. So I had to make a clinical decision. Now, the beauty of our office is we have started using, in the past 6 months, AI. Lou, talk about AI and how this plays a role in what we do every day, that you and I review our charts in the morning, and how it also plays a role in this particular case.
So I don't have enough time tonight to dive deep into Pearl. Pearl is one of 2 or 3 FDA approved artificial intelligence technologies to evaluate 2D imaging. So here we have a high caries risk patient. Now imagine you've taken the x-ray. Tony's now going to advance the slide. So as soon as you take that x-ray, within, I'd say, 1 to 2 minutes in our practice, and this will just appear in DEXIS, because we have DEXIS sensors and DEXIS software, immediately this pops up, this image. And as we go to the bite wing, instead of showing them a traditional bite wing that's been like that for 75 years, these images pop up. And pink indicates, a pink color box indicates caries. It's so easy to miss caries. I'm going to show you the beautiful part of Pearl in this case. Advance the slide. So now you focus on one particular image. And as you bring your cursor over, we're going to focus now on number 13. So let's now hit the next slide. As you bring your cursor over, and I'll say stop right there. Every pink dot in second opinion, and this is Pearl, I can't teach you Pearl tonight. Every pink dot with the pink arrow means there's caries on that x-ray. So artificial intelligence is telling you, click that, there's caries. So now let's go forward. So when you click it and you take your mouse and now click it again and you circle over the area, what will happen? Click it again, Tony. Now go back. I'm sorry. It's supposed to advance. Yours isn't. So when you click it, when you go into a box, it will tell you what percent is dentin and dentin penetration and how much is enamel. And you're going to see this in 2 cases tonight. Now imagine this. You now know the dentin penetration, enamel versus dentin. Let's go to the next slide. I can also measure. So now Tony was talking about this patient wanted 1 tooth at a time done. Well, I've got to do the deepest one. So I know I'm approximately 1 millimeter from the nerve, next one, on the mesial, and I'm 1.2 millimeters just using their measurement tool. So now, not only do I show them visually far more on a 2D image through Pearl, I can measure, I can zoom, and I'll show you far more in our second case. Tony, take it away. This is one more thing. This is called tooth parts. So you click on tooth parts, and now you're explaining to the patient, here's your nerve, here's your enamel, here's your dentin, and in the upper left, number 13, there are the boxes. And the boxes can show you how close the decay approximates to the pulp. And of all the teeth in this image and in his mouth, this was the deepest one. So now Tony and the patient decided we're going to restore number 13, and here's how they did it. Tony?
This is the slide that in this particular case I love the most because it visually shows me the difference in the anatomy of the pulp, dentin, and enamel, and how actual close it will be to that pulp. So again, at 24 years old, the goal was to avoid pulping out, as we refer it to. So this is the actual photo of the patient. And you can see here number 14, 12 through 13 and 14. And you can see the existing restorations in those teeth. The next goal was to maximize tooth strength and tooth preservation. As Lou said earlier, we want to do conservative dentistry. And what we mean by that is we want to maintain as much tooth structure as we can. Obviously, we want that strength to be there for that tooth and for the occlusion. So again, this all equates to think the process through. If you can see the end product and just work yourself backwards, that's what I do personally. But you have to think about it. Using your radiographs, using all your clinical skills, think about what you want to do here to give this patient the best restoration that you possibly can and be conservative. So Lou, talk to us a minute about what the research shares with us on caries removal.
So in 2017, the ADA published, and you can proceed to the next slide. The ADA published a retrospective study going back to 1962. And in 1962, Mertz and Fairhouse studied this, and there have been 47 studies since then. So this concept of selective caries removal, if you'd hit your next cursor, shows that all these studies found partial caries removal. And if you remove the majority of caries and leave, if needed, deeper caries and seal the restoration, you would reduce the bacterial numbers dramatically. So what does this mean? This means on this patient who's asymptomatic or maybe some cold sensitivity, you have every opportunity not to pulp out. And if you pulp out, you drilled too much. And you could say, Lou, there's decay. The research for now 60 years says don't pulp out. You can leave decay. You heard it. You can throw knives at me, but dental schools are teaching this now. So there's a stepwise way of doing caries removal. And the key is you got to remove all the caries around the enamel, and you should remove the dentin caries around the periphery. And if you're getting close to the pulp, leave the caries. I'm telling you again, leave the caries. And what you're going to do is reduce the cycle of root canal, crown. What happens with the crown? Recurrent decay, new crown. Then ultimately, we're getting into an implant. And so openly, we want to do minimally invasive dentistry. Next slide. So what we're going to show you is a quick technique. And the key is, as long as you can entomb the microorganisms, they're not going to have any nutrition to survive. And they will become what I would say, dormant caries or hardened caries. And that's exactly what will happen if we create a great seal. One more time. And so Professor Kidd found if you leave, again, infected dentin and seal it, it will not result in caries progression, pulpitis, or death. Next slide. I know this is different for everybody, but many of you are already doing this. So here's our next pearl. We've been using this burr in our practice for 10 years. It came out by Comet, a great burr company, and it's a ceramic burr. It can be sterilized by 100, 200 times. The beauty is, because of its Barkle hardness, and if you use this burr at 1,500 to 2,000 RPMs, it's like endodontically removing caries. You'll see the shavings start to come out. And when you want to stop, just stop. And that's called selective caries removal. Tony?
This is very frustrating, this burr, because I didn't invent it. But most of us went through dental school using carbide round burrs. And when they came out with this, I go, this is such a genius idea. You really need to have this as part of your protocol in your practice. It's an incredible. So this is, with all the decay removed, this was the preparation. Now we take a look at this, and yeah, there's a little nick on the distal of number 12, but it had an overhang, so I'm going to smooth that out anyway. But if we look at this, we have enough strength for the lingual cusp, enough strength for the buccal cusp. That lingual cusp will support the occlusion. So with the selective caries, we had no pulp exposure whatsoever.
So wait, before you stop here, I want everybody to realize this is the money slide. The money slide is, Tony again talked occlusion. If you break through that central fossa, you're tremendously weakening this tooth. And Tony said, there's your stamp cusp, the lingual cusp. There is absolutely no reason to put a crown on this tooth. You put a crown on this tooth, you have squat left. Start thinking, how do I keep this tooth for 40 years? And it's not just a quick crown. It's called doing the right thing. Tony?
So again, we want to maximize this tooth strength, as Lou just mentioned, and preserve as much tooth structure as possible. So I've placed a final bevel. And when we use a bevel in our office, we use finishing burrs at reduced high speed at 50,000 RPMs. This football, actually Lou showed me this when I got to the practice, works wonderful for this because it just gives you a beautiful bevel to adapt your composite to. So I hate to say this, but Lou knows probably more about pulp capping than most dentists I've ever met. So Lou, talk to us a minute about pulp cap, or not pulp capping, protecting the pulp.
So what really is important is the concept of selective caries removal, and what do you put over this deep area that still may have caries? You're not going to bond to it. Why would you bond to caries? You get no bond strength. So what do? Tony? What we're going to do is we're going to use a calcium hydroxide liner. Now you can say, well, there's so many liners on the market. No. You want to use a calcium hydroxide liner. You don't want to use a fluoride liner. You don't want to use any liner with fluoride. You don't want fluoride near the pulp. Let's go to the next slide. So these liners we use are for multiple reasons. And I'm going to go through these, but they're antibacterial. They seal the dentinal tubules. They remineralize dentin with secondary or tertiary dentin, and they protect the pulp from negative side effects of restorative materials. Like, what does that mean? When you put a bonding agent on, it's inflammatory. It can be inflammatory. So now we're going to block the bonding agent, and I'll even tell you a little bit more in the next few slides. So the first thing you have to understand is these monomers are very hydrophilic. Hydrophilic is essential to understand.
Sorry.
That's okay. Go.
There we go. Sorry.
Why is hydrophilic important? I don't know why that's, go back.
All right. It's changing on its own.
Okay. Hydrophilic is, it's okay, I know the slide. Why is hydrophilic so important? Understand that when you put a liner that is hydrophilic, it will be attracted to the tubular, it's attracted to go deeper into the dentin by following the tubular fluid. And as it follows the tubular fluid in, it will release calcium as the calcium hydroxide breaks up. Now, I'm going to explain what happens when the calcium hydroxide breaks up. But the calcium's following into the dentinal tubule, creating tertiary or secondary apatite. Next slide. The calcium exchange internally along the floor and in the tubules is what is creating the remineralization. Next slide. Here's the key. There are many, and I'm not going to call out names. There are many liners with fluoride. Fluoride is toxic to the pulp. If you even read a glass ionomer DFU, it will say put calcium hydroxide below a glass ionomer to protect it from the fluoride of a glass ionomer. So you want to put a calcium hydroxide liner when you're approaching the pulp or nearby. Next. Insulating from heat. Two types of heat. One is the exothermic reaction of the composite. When a composite cures, it releases heat. The second is the heat from the light. So if you're deep, the last thing you want to do is create any pulpal increase in temperature. Now, the studies go that's pretty rare, but the liner itself will protect it, and these liners have low solubility. They just can't be thick, less than literally a millimeter or less, because they don't have flexural strength. Next. So here's a key slide, alkalinity. Alkalinity, and hit the slide, Tony. Alkalinity is critical, everybody. Why? So here you have calcium hydroxide. When you place it on a tooth, the calcium hydroxide dissociates into calcium for remineralization and hydroxyl ions. Now, you don't see this. I'm just telling you what's going on. The hydroxyl ions create an alkaline environment. Alkaline environments kill bacteria. Okay, so you've left decay, which are bacteria. You put a liner over it, you're going to light cure this, And what will happen is the environment is alkaline, so it's bactericidal. So more efficient than just etching and bonding and putting a composite over remaining decay. And that's my 2-minute pearl. Go on, Tony. So there are an array of liners today. There's Ceramur Protect LC, Limelight, and Theracal. I will just say this. If you Google Nate Lawson on Ceramur Protect LC, he starts to highlight which liners release more calcium. I leave it to you, but these are all 3 wonderful liners. Next. So here's the technique tip. You must apply a hydrophilic material on a wet tube. So what you do is you just take a micro brush, put it in a little dapping dish with a little water, put your micro brush in, wipe it on the patient's napkin, and now stroke the dentin. And all you're going to do is create a barely moist surface. But what you'll see is when you inject your liner, it will flow. As it flows, it will now follow the tubular fluid. It will follow the dentin. And just if you need to manipulate it with an Explorer, let it flow a little more and like here for 20 seconds. And now Tony will take you away. Tony, take it away.
I hate it. I told you he knew his stuff. So here are the steps. I removed any excess cured liner with a finishing burr. I don't want that in any of my cable surface margins. And so I make sure that I remove any excess. Then I placed the sectional matrix bands with rings and wedges. And in this particular case, again, I preferred the selective etch, but you can, again, and as Lou mentioned earlier, we take the surgical suction, remove the etch, rinse, and then we blot dry. I applied zip bond. Now, what Lou talked about and we talked about is we scrub our dentin. We cannot emphasize enough how important this is because, again, you want to form that layer and you want to make sure that that agent gets into the dentinal tubules. And then we, of course, take our dedicated air and lightly 5 seconds and then 10 seconds, we thin that and we evaporate accordingly. And then we're going to apply a flowable, and then I'll put level in the Luna 2. In this particular, here, this is a slide that talks about the flowables. Now, Beautiful, which is made by Shofu, they have a stackable and they have a low flow. You would use a low flow. I use a low flow in a cervical box, but you would use a stackable in areas where you want to build up. So I prefer the low flow in the cervical box to adapt to that preparation.
Okay, so just a point of difference here. I prefer a bulk fill flowable of these 3 because they all self-level.
Yes.
The low flow doesn't necessarily self-level. So in the bottom of a box, all 3 of these, Vocos, Dentsply's, and Shofus, and others, you got to know this, you want it to self-level.
Yes.
So for me, these are, I love the low flows of Shofus for class 5s and others, but Shofu's bulk fill flow here is important because it will self-level just like Surefill SDR and extra base. That's just my 2 cents. Keep going.
So this, again, is what we started with. My selection of shade was the A3, before and the after. So the restoration, we were able, sorry about that. I don't know why that did that, but we were able to do a minimum prep as far as, I don't know why that's, we were able to preserve tooth structure. We have occlusal strength, and we ended up with a very nice conservative, somewhat conservative, and a strong restoration. Comment, Lou?
Nope, keep going. We got time.
All right. Our next patient, learning from failures. This is, I did an initial exam on this patient, and tooth here, number 29, you can see has a composite filling and it has recurrent decay around it. So, Lou, let's talk about AI on this.
So this is my analness. So AI with Pearl obviously can show you the decay. Let's click forward, Tony. It will show you the depth of the decay and how deep the dentin is, or the dentin involvement. And in this case, only 2% in enamel. So I know I'm going to be deep. Let's keep going. But I think what's important here is to look at the value of what Pearl does. So what we did was this was a new patient. We got their old x-rays and we put them into our system. And we actually got to see what the dentist had 2 years previously. So as I look at this x-ray in 2019 of the same patient, Pearl evaluated this tooth as 100% in enamel. So in 2019, 100% in enamel. Go forward, Tony. One of the techniques with Pearl is you can zoom, and I'll show you zoom in contrast. So you zoom, and then you can evaluate. So as I'm zooming and hit it again, I know I'm still in enamel. This is in 2019. In contrast, again, hit it. I'm still in enamel. So 2019, still in enamel, zoomed in contrast. Keep going. Even in tooth parts, I can see I'm still in enamel. Go on. So now 2021, prior to this restoration being done, and it was done, I assume, right around that date, this restoration is 100% in enamel. Now, please note, everybody, this is a low caries risk patient. I feel this restoration should never have been done. So I'm diagnostically saying, if you have Pearl here, it should be helping you, guide you to low caries risk patient. Nothing's changing year over year. To me, this should never have been done. But that wasn't the case. It was done, and this is how the patient presented. Tony?
So what I had to evaluate is, after 1 year, what caused this failure with the amount of decay? And if you've been in dentistry long enough, you will learn from your mistakes and mistakes of others. And it wasn't too hard to figure out when I asked the patient to bite down exactly what caused this failure in this restoration. When the dentist initially placed it, there was no consideration, in my estimate, of the opposing occlusion. And thus you had a plunging cusp. Without question, as the patient bit down, I examined, here comes the opposing cusp right down into that restoration. So as before, I placed a liner, removed the decay, placed a liner, and just like in the previous case, we ended up with a very nice restoration. I just want to say that this photo was taken immediately, and I absolutely love the shade matching on this restoration. I did not have to adjust the opposing, because when I did the final check, I was able to keep this restoration out of occlusion from the opposing cusp. Comment, Lou?
Nope.
All right. In the next case, it shows a little variation. Like many times, dentists will ask, how do you place your matrices when you have adjacent restorations? And this shows a look back to the days of amalgam for some of us, but this restoration was failing, plus there was decay on the distal of the adjacent tooth. So I took the decay out, conservative preparations, and placed a Toffelmeyer. I placed the restoration, the filling into the Toffelmeyer and that MOD, and then I followed it with a DO with a sectional matrix and polished it. Let me go back, polished it here. And then we ended up with two very nice restorations with a nice contact and with a chameleon effect. The next patient, and we all see these, and this patient literally says, and you can see the redness of the gingiva, I'm tired of getting food trapped here. Well, I had to make a clinical decision, and I asked the patient, my first question was, would you ever consider orthodontics? And the patient said, nope, I don't want to go through braces just to close that. And then we have the capability of BioClear. If you don't know what BioClear is, please check it out. But it's a matrix system that can be used. A lot of times people use it for closing dark triangles in the anterior, but that was a possibility here. But my concern was this patient's occlusion with no support. It would be very difficult to get good support. And I checked that. We had this situation of a possible plunging cusp in that. So I did not want to use that. So I decided to do a very small, very, very conservative class 2 preparation. And this is me applying the zip bond after the very conservative preparation. Applied it for 20 seconds, scrubbed it, went through our routine of air drying, and I cured it. Placed the flowable in the box. And it's very important when Lou talked about light curing, one of the things that we as clinicians, we get in a hurry when it comes to our light curing. I can't stress enough how important this is to make sure you get all the angles. Because if you have the slightest, if you've removed a previous restoration or you have a slightest undercut, your light may not be getting to either your bonding agent or your flowable or your composite without angling it at different directions. And it's important that this composite all gets cured. Comment, Lou?
I would say this to everybody on here. Couple pearls. Pearl 1, when you're using a self-leveling flowable in the bottom of a box, flowables take longer to cure than hybrid composites because they're more resin containing, and resins spread light. So when you're curing the bottom of a box, you cure for at least 20 seconds. If it's a deep box, you're going to cure 30 seconds. If you're going to use different shades, use a lighter shade. A darker shade or an opaque shade takes longer to cure. So in the bottom of a box, just use an A1 or a universal color so it will cure in 20 seconds. But if you're curing deep, go 30 seconds and use these different angles to make sure everything is light cured. Quick pearl, go.
Yeah, and make sure that you keep your distance. We don't want to fry that pulp from this light.
No. I disagree. I want to be clear here. Go back. You want that light on top of the tooth because the further away you lose light energy. If you're near the pulp, you protect the pulp with a liner. You have to have that light smack on that matrix band. You are absolutely curing it as close as you can because distance will absolutely decrease bond strength. So come as close as you can. Keep going.
Okay. So this is the close contact, and the patient was very pleased. I actually had a follow-up with this patient in hygiene a couple of months later, and she was very thankful for this. Our last patient tonight has to do with bruxism. There's no question that this is commonly seen every day in our practice. There was not a burr placed to create those striations on that cervical area. So it's a situation where, in fact, in many of these cases, I will not even give anesthetic. And this can be done very, very conservatively. What I will do is I will remove those striations and I will create a bevel. And my preparation is like a half moon shape with a bevel as you go towards the incisal. So I'll make sure there's no decay and I'll reduce the speed on the high speed, and I'll just create a very, very small conservative prep. I just want to make sure that I have a good, solid foundation in which to place a restoration. So what causes this? This is something that there's so much controversy over the years as to what causes cervical adfractions. Well, I think literature pretty much points out nowadays that it's the wear and tear, the wear of the dentition that causes these. Bruxism, clenching, grinding, that's where we get these in most cases. So thoughts to restoring. Do you isolate the area with retraction cord after the preparation? In this particular case, that wasn't necessary. It was all above the gingiva. Do I bevel the coronal area of the preparation? I did. I want a nice bevel so that I could flow that and meet that enamel edge and make sure it's beautifully nice and smooth. Do you micro etch the area? You can. In this particular case, I did not. And I total etch this. I used total etch at that time. Sometimes I will use a flowable composite. I did not use a flowable composite on this because I wanted to get a very nice aesthetic shade, which you can with flowable. But Lou talked about earlier how fantastic Luna 2 is when it comes to handling. This is such a unique property, especially in the cervical area, that it just, you can actually manipulate that just wonderfully in that area. Advance. So this is again what I used for the bevel, as we showed earlier. Reduce it to 50,000 and it creates a wonderful bevel. And this was the final restoration with the A3. You see I did irritate the gum a little bit, but this in a matter of days will go away. And we created a very nice restoration. And I thought that the shade just came out wonderfully matched and great restoration.
So Tony, to your point here, what I would say is I loved warm composites.
Yes.
And so for me, I'm a flowable guy in general around class 5s. So when I'm doing class 5s like this with Luna, I love to warm the composite. First off, there's a lot of enhancements when you warm composite, but when you warm it, I just feel like I can, even with the great handling it has without warming, with warming in a class 5, I really feel I can sculpt it and really handle it well. I get it not warm, but I also love to warm it. Go on.
Absolutely. And I agree. Yep. All right. So let's take some questions. Sorry about, we have to advance the slides, but when you're in 2 different locations, it's pretty hard.
So I'm going to answer some questions. And the first question, and I'm going to go back, and if you guys have questions, please type them in. So the first question tonight was, when I'm air drying, when I'm air drying after I've scrubbed my bonding agent in, can you take surgical suction and surgically suction to remove the solvent? And is that good enough? Now, I know there are other speakers out there that espouse to that. We'll go without names. I personally feel surgical suction is fine initially, but the studies all show that if you air dry at a distance and then come closer, you get a far more efficacious way of removing the solvent. If you leave the solvent, you lower the overall bondability. So I don't believe in surgical suction only. If you're using a thicker bonding agent, you may surgically suction, and then I would air dry appropriately, 5 seconds at a distance and then 5 seconds closer. Tony, any comment on that?
Yeah, I agree. I think it's important because you're going to either have an acetone. Zip bond is the ethanol-based solvent. And I agree. I don't want anything after I've scrubbed that agent on there, that bonding agent on there. I don't want to mess with those dental tubules. I just don't.
Well, so let me just say, I don't think you're messing. Let's get consistent here.
Okay.
My thing is if you take a surgical suction and you come close to touching that enamel surface and there's water on it, now you've contaminated what you just etched and bonded. So I think you're kind of, everybody, you're overcomplicating it with the surgical suction in that case. So surgical suction is when you rinse your etch. I want to be clear for everybody. I'm air drying at a distance and then closer.
Right.
That's what I'm doing. Now, there are other questions. I want to answer each one, and I'll have Tony. Next question, is there any limitation with 2D AI Pearl, such as overlap? Does that limit the ability to detect caries at its depth? So let me explain Pearl. Pearl can only evaluate as good as the image.
Mm-hmm.
Now, Pearl will tell you they are not perfect. it is a trained computer with millions of x-rays. And basically Pearl has trained the computer how to read. It's unbelievably accurate, but nothing is perfect. If you have a bite wing x-ray that overlaps two teeth, you cannot count on Pearl. You need to take another x-ray. You must be accurate in your technique for Pearl or you with visualization to evaluate that. Okay, that's the second question. Now, next question is, and I'm going to get to all the SDF questions at the end. So Tony, Belinda asked, do you cure the restoration again after removing the matrices? I have my answer. What's your answer?
I do. I do take the light down in the cervical area, and I cure it from the buccal and from the lingual in most cases. What I also will do is, I'm a fanatic about this. I take a number 12 surgical blade scalpel, and I actually trim any flash that may be down there if there's happens to be any overhang or anything like that. I just make sure that cervical area is nice and smooth and clean.
Okay. Now, so for everybody, you take off your matrix band, and the reason you do a post-cure interproximally, 10 seconds interproximal from the buccal and the lingual, is to maximize the conversion of the composite. So the answer, Belinda, is every time I take off a matrix band, every time Tony does, you light your interproximally 10 seconds, buccal and lingually. Okay. Next question regarded, what are your thoughts about Theracal LC as a liner rather than calcium hydroxide? Okay. Theracal LC is a calcium hydroxide liner. So the person who asked it, I want you to understand, Theracal is calcium hydroxide, like the others, with a resin component, which makes it light curable. So just understand Theracal, made by Bisco, is a calcium hydroxide liner, and it is a very good one.
It is. It's very good. You and I both have used that, Lou, over the years.
Right. I have just shifted. And again, we're an open group here. Bisco makes a great product. And for years, that was my call. Doxa, per Nate Lawson, shows that Serum Protect LC as the next generation of calcium hydroxide. It releases much greater calcium levels. I don't know about Embrace Enhanced from Pulp Dent. And so I'm just going by Nate Lawson's study, and I go with right now Serum Protect LC. But again, Theracal LC is a calcium hydroxide liner, and it is a very good one. Okay.
And the takeaway on that, Lou, it's for everyone to remember is make sure you have a little moist surface when you apply that calcium hydroxide liner, please.
So now the next question is, what is your recommended warming method of composite, the most efficient system? You want to take it or you want me, Tony? You pick.
No, go ahead.
So the latest opportunities, Gabriel, are basically warming guns.
Yeah.
Voco has come out with their warming gun. CalCet has come out with theirs. I think guns are fine. I really do. But openly, I just prefer the CalCet warmer. The CalCet warmer allows you to warm your instruments. You can warm your anesthetic, and you can warm individual carpules. So I'm warming everything in mine. And so what happens is with the guns, if you extrude a little bit, you have a certain amount of time with the guns that I have found.
Right.
But if I'm using a CalCet warmer, what I do is I'll inject some, and then if I'm doing incremental, I'll put the gun right back in the CalCet warmer, and it keeps the compule warm so I can go back, and back. So I'm a CalCet warmer lover. Now, you can warm composite like in a coffee heater, but again, it's not going to warm your instruments. It's just warming your carpules. It's fine, but I still believe I'd rather just invest in one I just have CalCet warmers in every operatory. That's just my thought on warmers.
I agree. I agree with that, between that and the guns as well.
Okay. So next question is, from a very prestigious friend of ours. In a high caries risk patient and restoring with a large cavity, after the calcium hydroxide liner, would a glass ionomer sandwich be best in the box, best to help manage caries risk? So let me explain this to everybody. Now we're just sharing. I know we're beyond our time, but now this is just pure education. So the question really relates to, do I put a glass ionomer in the bottom of a box in a high caries risk patient, or do I put a self-leveling flowable? And that's the question. Now, I have my answer. Tony, do you want to answer?
Yeah, in our practice is about 30% geriatric patients. So we see decay that no one ever wants to see, and that's root decay deep. So for years, I would put a glass ionomer down deep first. After the liner, I would place that glass ionomer in the cervical area without the flowable. But I have changed that over time, because now with our bioactive materials, I had to make a decision, and I'm right now I'm placing some bioactive flowables and waiting to see the results I get. So that's my answer.
So, and my answer would be to this point. What I have found over the last 10 years, when I put glass ionomers in a class 2, when we call that an open sandwich,
Yep.
I have found that between acid erosion and hygiene ultrasonics, I have seen ditching of true glass ionomers. So yes, I believe glass ionomers as a small core buildup, or as even in a class 1 in a non-load bearing area, they're amazing. But in the bottom of a box, as a definitive restoration, I'm going to again agree with Tony. There are bioactive restorative materials, such as, there are 2 companies that have released them. One is that we just reviewed is Presto. It's a flowable, and it's very similar to the Activa bioactive restorative, but it's a flowable, little different chemistry. And that could be a great opportunity. Putting Shofu's flowable in the bottom of a box with its geomer chemistry is another opportunity. Yeah. So, and Tony, you were using Vista Apex's product,
right?
And you were using that regenerative material in your bottom of your boxes.
Yes. Yes. Yep.
So I would just say I've moved away from glass ionomers as a long-term solution. As an immediate temporary solution, Mark, I think they're great. Next question is directed shrinkage just as good as flowable? Is directed shrinkage just as good as flowable plus sculptable? I can't answer that question because I don't know. So I want to get to a few more, and I know everybody wants to end, and I apologize, but I'm trying to be courteous to questions because they're flowing in. Do you advise silver diamine fluoride on remaining caries? And here's the issue with that. If you put silver diamine fluoride to treat remaining caries, which absolutely works, the studies show you have to put a glass ionomer type base over it. I have tried resin bonding over SDF, and I have seen so many debonds because I think it does affect bond strength. So I think to the multiple questions on this, for the patients who can't afford root canals and you want to SDF, my recommendation is we use SDI's Riva Aqua, which is a non-ammonia SDF material. We'll use that, leave the decay, and then we'll pack a glass ionomer in. Then you would go back in potentially and re-prep out the glass ionomer or leave it as a base at a later date, or you just use the glass ionomer as a base,
right,
and then prep the base after it sets and then put a composite over it. But yes, I believe in SDF. I believe it's entirely effective, but you have to put basically an RMGI or a glass ionomer over it. That's what the studies show, and that's what we've done. Tony, any comments?
No, I agree that you just don't get the bond if you don't do that. You just won't. I mean, it breaks down. It just won't last.
Last couple questions then. Currently using biotene or Brasseler's root repair material for indirect pulp caps. What are your thoughts on using SDF at the deepest point to improve the prognosis? And that's a great technique. If you're doing SDF and biotene afterwards, which is not an easy material to work with, I think that's an absolutely great technique. And then you put your composite over the biotene. I have absolutely positive things to say about that technique. So thank you for that. Last questions. Oh my God, there's so many. Okay, won't be the last. When you do a flowable at the bottom of the box, I'm going to let Tony answer this. Tony, I'm looking at your bald head. Lift up.
Sorry.
Tony, when you do a flowable at the bottom of a box,
yeah,
do you cure it after placement or place the composite over it?
It is a great question. It wasn't that long ago, Lou and I were at a meeting with Vista Apex and their Regen product. And John Kanka, for many of you for those that don't know it, John Kanka is the dentist that founded the wet etch technique. They now have a procedure where after you etch, you place your adhesive, you place your flowable, you place your composite, and you cure. So you want to talk about time saver. Most of the time, dentists, and we do as well, we will cure at the flowable as we place the flowable. And I have done it both ways, and they both ways work. So with the right, it has to be, I'll answer it this way. With the right bonding agent, you can cure your flowable and your composite at the same time. Lou?
So for me, what I do at the bottom of a box, let's just call it, if I'm using Circle SDR or a self-leveling flowable of whatever you want, an extra base. I like it to self-level. I like to light cure it to 20 or 30 seconds. This is what I do. Mm-hmm. Then what I do is I've cured it. I then inject a little bit more into it and do not cure the second layer. I inject a little bit more, and then I take a little warm composite and I place the warm composite into the flowable that's not cured. And that allows a beautiful second layer or a final layer. So that's called the snowplow. So I cure the first layer routinely, and then the second layer has a little flowable and warm composite, and that's my technique. So there are many techniques, but I always cure the first layer. Yep. And the reason is because of depth. I want to make sure I get a solid cure because I don't want any micro leakage.
We want to protect that cervical area for sure.
Okay. Now wait, I'm just going to end, then we're going to end this. I promise. But thank you for all your questions. Just want to make sure. So there are way too many continuing to come in, but I think we've really answered a lot of them. And I think this is great.